Participants Caleb argues for cuts, downsizing, budget discipline, efficiency. Julian argues against cuts, health, equity, provider stability. Caleb, let's separate goals from instruments. The goal is better health at a sustainable cost. The record shows Medicaid expansions brought big spending increases, more visits, and, in randomized data, no significant short-run improvements on several physical health measures. If a program can't demonstrate commensurate health returns, tightening it, by scaling eligibility or benefits, or at least slowing growth, is reasonable. Julian, you're cherry-picking a 2-year window. Broader evidence links Medicaid expansion to lower mortality, earlier cancer detection, and massive financial protection. That's not noise. Cutting coverage means more uninsured people facing medical debt, delayed care, and avoidable deaths. Those are the highest stakes outcomes in health policy. Caleb, mortality associations come from quasi-experiments that can't fully rule out confounding. Meanwhile, the randomized Oregon results are clear about utilization surges, particularly ed-use. If the marginal dollar buys more low-value visits, we should be skeptical. And remember budget reality. Every program competes with education, infrastructure, and debt service. Julian, Oregon also showed dramatic reductions in catastrophic out-of-pocket spending and improved mental health outcomes. Your frame discounts. And hospital finances improved after expansion because uncompensated care fell. That kept rural and safety net hospitals open. Cuts would reverse those gains, risking closures that hurt everyone, including the insured. Caleb, hospitals should be paid for care, yes, but that doesn't require blank check coverage expansions. You can subsidize safety net providers directly, or design targeted high-risk pools, without open-ended entitlements that encourage overuse. We should also worry about labor supply. Evidence shows some people reduce work when public coverage is available. Julian, that labor supply effect is small and often welfare-enhancing. People leave jobs tied solely to benefits, reducing employment lock. If we want efficient labor markets, decoupling insurance from employment helps. And overuse isn't a fate, it's a design problem. Navigation, after-hours clinics, telehealth, and value-based payment steer patients to the right care at the right time. Caleb, if design fixes are so powerful, why haven't they solved ed surges and long waits already? Medicaid still has low physician acceptance in many places. Coverage without access is illusion. Rather than pouring money into a leaky bucket, we should tighten eligibility and refocus on building supply and incentives first. Julian, physician participation rose in many states after payment bumps and managed care contracting. We know how to raise acceptance, pay for access, not just codes. Moreover, the gains from coverage are largest for people with chronic illness, mental health needs, and financial vulnerability. They don't have the luxury of waiting for a theoretical supply build-out. Caleb, it's not theoretical to demand measurable value. Let's tie federal matching rates to states hitting access and value metrics, primary care appointment availability, ed diversion, blood pressure control. If states miss, they don't get the extra match. That's discipline. If they hit, fine, keep coverage. But automatic expansions with loose accountability invite waste. Julian, I'm all for metrics and accountability. Where we differ is the starting point. Start from preserving coverage, because the preponderance of evidence shows it reduces death and financial ruin, then layer discipline. Your approach gambles with people's coverage to create leverage. That's risky governance. Caleb, it's not a gamble to recognize opportunity cost. Dollars spent on broad subsidization might buy more health if redirected to maternal health bundles, opioid treatment, or social determinants. Cuts can be paired with targeted reinvestment. Coverage is not identical to care, and not all insured care produces value. Julian: true, coverage isn't care, but it is the gateway to care. Without it, patients delay until conditions worsen, which is the least efficient path. Instead of cuts, respect the benefit, $0 primary care and generics, smart copays for non-urgent ED visits, and aggressive care management for high-risk members. Those steps reduce waste without throwing people off insurance. Caleb: even then, the open-ended federal match blunts state incentives to control costs. We should cap growth or shift to block grants with quality guardrails, pushing states to innovate and cut waste. Julian: block grants shift risk to states and patients. In downturns, needs rise just as revenue falls. Coverage cuts are the predictable response. That's precisely when Medicaid's counter-cyclical design is most valuable. If we want innovation, fund pilots, share savings, and scale what works, without removing the safety net when it's most needed. Caleb: so would you accept trimming eligibility at higher income levels, where crowd out of private coverage is most likely? Or tightening benefits in areas with little evidence of value? Julian: I'd accept phasing out subsidies where evidence shows little marginal benefit and reallocating to high-value care. But I wouldn't cut the core eligibility expansions for low-income adults that delivered the biggest improvements. And I'd finance access, raise primary care rates, enforce time-to-appointment standards, and pay for outcomes. Caleb: then we at least agree the program needs re-engineering. I want hard budget caps and stronger work incentives. You want access guarantees and value-based care. The synthesis might be, preserve core coverage, impose performance-based federal matching, and expand ED alternatives before any further eligibility growth. Julian: and I'd add, ban cuts that would raise mortality or shutter safety nets, publish transparent dashboards, mortality, financial hardship, appointment availability, and let those numbers govern adjustments. If the data show a policy saves money but costs lives, we shouldn't do it. Caleb: data governance is fine by me. Put sunset clauses on payment add-ons, require reauthorization based on results, and keep a running tally of cost per quality-adjusted life year saved. If coverage wins on that scorecard, it stays. Julian: then our case to the public is honest. We'll keep people covered, make it easier to see a clinician, cut waste with evidence, and hold states accountable. That path protects lives and tax dollars better than blunt cuts. Caleb: provided the accountability is real, and the budget has a backstop. Otherwise we just promise everything and pay later. Julian: real accountability, yes. But no cuts that undo the gains most of the literature attributes to Medicaid, ACA coverage. We can be disciplined without being destructive. Caleb: fair. Let's build the dashboards and let the results decide. If coverage delivers value at reasonable cost, we'll both defend it. If not, we'll both change course. Julian: deal. Evidence first, ideology second. That's how health policy should work.